Hi, my name is Bianca Dominguez, and I'm going to be talking to you about a rare case of lupus presenting with neuromyelitis optica. So just to start off, neuromyelitis optica, known as NMO, is a rare neurological disease. It used to be thought to be a subtype of multiple sclerosis, but with the discovery of the NMO IgG or anti-aquaporin 4 antibody, it's now recognized as its own distinct entity. Like most autoimmune diseases, it is more common in women, with an incidence of 0.5 to 4.4 per 100,000 people, and age of onset is typically between 35 and 42 years of age. So clinically, it presents with attacks of transverse myelitis and optic neuritis. On imaging, you can see contiguous spinal lesions in greater than equal to 3 vertebral segments on MRI, and of course, positivity for the NMO IgG antibody. NMO can be associated with other autoimmune diseases, but can also present as its own primary autoimmune disorder. So I'm going to tell you about our patient. She's a 54-year-old Black female with a past medical history of asthma and gallstones. She came into the ED with a lot of seemingly unrelated complaints, including chest pain, dysphagia, generalized weakness, diplopia, and paresthesias in her feet. Initial vital signs are within normal limits, and there were no focal deficits on exam. So she kind of had a broad workup, ended up being diagnosed with an acute pulmonary embolism, a new diagnosis of cardiomyopathy, and had an MRI brain that revealed an area of hyperintensity in her cervical medullary junction, as seen below. She had a full rheumatic and infectious workup and ended up being diagnosed with lupus, so she was treated empirically for suspected lupus myelitis with Solumedrol daily. She didn't really have a whole lot of improvement on this regimen, unfortunately. Ended up having increased workup breathing and nystagmus. She had a lumbar puncture that came back positive for the NMO IgG antibody and was subsequently treated with plasma exchange for 5 days. She then was discharged to inpatient rehab on oral prednisone, and while in rehab, she did well for a couple of days, but then rapidly declined, became unresponsive, and developed acute hypercapnic respiratory failure, resulting in intubation and transfer to the ICU. At that time, neurology started rituximab infusion. She remained in the unit for around 8 days and unfortunately didn't really improve much on the rituximab after 2 courses, and that prompted repeat MRI brain imaging, which showed worsening of the initial findings. At that point in time, the neuroimmunology team recommended cyclophosphamide and oral prednisone on a taper, and she was discharged. So just kind of to backtrack about these antibodies, this NMO IgG antibody is specific to NMO as a disease and bind to the water channel aquaporin 4. That's why they have that name. This channel is the most expressed channel in the brain, spinal cord, and optic nerves. And around a quarter of patients with the antibody-positive NMO can have underlying autoimmune disease. That's why it's really important to test for this antibody in patients that may have other autoimmune diseases, like our patient had lupus. Treatment of NMO begins with high-dose steroids for 5 days, followed by oral prednisone, 1 mg per kg. And if patients don't improve on this regimen, then usually plasma exchange is recommended for 5 days. Long-term treatment of NMO includes several immunosuppressants like mycophenolate mofetil, azathioprine, and rituximab. And rituximab has been associated with reduced rates of relapse by about 88.2%. So just kind of to conclude, one of the reasons why we wanted to talk about this case is because prompt diagnosis and treatment of NMO is very important. Delay in the treatment can result in severe debility in patients, and if untreated, around 50% of patients will have to be wheelchair bound, and many of them can have permanent vision loss and blindness. So we wanted to highlight the importance of, recognizing NMO as a distinct entity, and also recognizing that it can be associated with people with underlying autoimmune diseases, and to not just attribute a patient's neurological manifestations to their existing autoimmune disease. So thank you so much for your time and attention.